So there's one clinical case focused on diagnosis issue, and the second one will focus on therapeutic approach in adult patients. So the first case is Mrs. E. She was born in 1949. She was from Portugal and lived in France since she was 25 years old. She had no consanguinity, and she's non-smoker, and she doesn't have allergy. She's complaining of daily sputum, but she cannot tell us what happens during childhood, like very often in adult patients, and we do not have information about postnatal period. So we had maybe a history of whooping cough and measles, and that's all. And she had also chronic sinusitis, but she says she doesn't have a fertility problem, but she never tests fertility, actually. So when we try to find more precise information about her history, we discovered that she had a diagnosis of bronchiectasis in 1978. So she was, in fact, 20 years old at this time, and she had bronchiectasis in the middle lobe with atelectasis, and at this time it was performed by lipidal bronchography. It's a technique we don't use anymore. And functional test at this time was show FEV1 in 1.9 liters, so it's a small obstructive defect, and we don't know exactly what will be the etiological workout for bronchiectasis, but at least the alpha-1 antitrypsin level was normal, and she had also IgG, IgM, and IgA levels normal in blood. So she had a very erratic follow-up between Portugal and France, and she came back in France, and we have seen her in outpatient clinics in 2021. And at this time, she had worsening of symptoms and bronchial exacerbation. And a few months ago, she started azithromycin chronic treatment, and also she had very often oral corticosteroids. So we decided to perform a new chest CT scan. And as you can see, but you can see, of course, the chest X-ray, which is difficult to make interpretation. But for the CT scan, you can see that she had bilateral bronchiectasis, and they are predominantly in the lower lobes and middle lobes, but there is not so much abnormality in upper lobes. She had also a sputum analysis, and we found a Pseudomonas aeruginosa and also a Achromobacter species. We performed a walking test, which was not excellent, 273 meters. And we performed also some biological tests. We looked at the autoimmunity, and it was negative, and she had a second time IgG, IgM, IgE levels normal in the blood, and specific IgE to Aspergillus was negative. And she had a normal sweat test, and extensive CFTR gene mutation analysis, and it was negative also. So that's a poll. Should I stop my screen, or?
No, you can just continue like this. Now
okay.
People can choose the poll.
Because I am full screen, I cannot see when I should start again, but that's okay.
Yeah, that's all right. We just give them maybe a couple more seconds, and then I close the poll, and we'll see what ideas the audience might have. So no more new answers. Let's close this. So that's what people thought of. However, only 4 people actually were brave enough to participate. Most of them thought they'd like to do a lung function, nasal biopsy. One would do a genetic testing, and one said all of the mentioned exams. Thank you. So you can continue, Bernard.
Okay. So first we perform a functional test, of course, and I'm sorry because it's a French text, but as you can see the FEV1, you can see there is a 1.7 liter, so we represent 50% of predicted value in this patient, and she has no response to bronchodilatators. And we also want to have a more precise evaluation of sinus. And so we perform sinus CT scan, and as you can see, there is frontal sinus hypoplasia, and she also had opacities in the left maxillary sinus. And she had also a audiometric test. Again, it's in French, but still you can see that there is a combined hearing loss in both ears for this patient. And an ENT physician looked inside the ear, and he observed tympanic sclerosis in both ears. So since she had a sinopulmonary syndrome, we decide to exclude the PCD. And so we perform first nasal NO, and as you can see, the level is low, but it is really just at the lower limit. So it's not decreasing a lot, but still, because we have for us a high clinical probability, we decide to perform nasal biopsy, and we were able to see 72 cilia, and you can see that 50% of cilia had central complex defect. And after that, we perform a gene analysis, and we found a mutation in RSPH1 gene. It was a homozygous mutation. So finally, I mean, she had the PCD diagnosis when she was 73 years old. So I think this case illustrate sometimes the difficulty to perform a final diagnosis in patient. So it's true that symptoms can be very different, as represented in this slide, during childhood and also during adult life. And it's true that in adult life, normally we should find the same symptom as for childhood, but we often have also information about fertility. So you know that a score called PCADA score has been designed to help the diagnosis of PCD, but you can also see in this slide that several items are focused on neonatal period, gestational age, very difficult to get when you ask adult patients, neonatal chest symptom, neonatal units, and so on. So it's probably a very good test for young children, but it's very difficult to use this test in adults. So in adults, it's true that we often had missing data for neonatal symptoms. And for the ENT or the upper airways area, we lack generally symptoms for middle ear otitis, but at examination, we can observe very often tympanic sclerosis. And it's true that if we ask again, patients generally told a story of ear infections. And in adult patients, mostly they got rhinosinusitis symptoms. The most important, at least for me, in adult patients, that they always had bronchiectasis in CT scans. They are almost bilateral in all cases, and they are predominantly in lower lobes, as you can see in this presentation. And this has been made by the English group in London. So you mean 83%, 85% in the left lobe and right lobe for the patients. And of course, hypofertility can be associated in this patient. But if we look for the everyday practice for adult physician, it's true that we have a lot of different diagnoses in bronchiectasis patient. This is a slide, from the EMBARK study, which is a very big European bronchiectasis registry. And, here you have the list of the diagnosis the investigator made. We don't have very precise information about the test, of course, and the tool, but you can see there is a lot of different diseases. And as you can see also in these diagrams, it's the diagnosis percentage in each country. And you can see there is a huge difference in Europe. So make difficulties for adult physicians to perform a specific diagnosis. So this slide shows a list of specific diseases in adult patients, and I just put in bold very frequent diagnosis in patients. But if in our case, if we focus on sinopulmonary syndrome, we can say that we can have immunodeficiency diagnosis. We can have also congenital disease. And maybe in Sjogren disease, with the dry syndrome, you can have also upper and lower airway disease. So to try maybe to find a specific predictive score for PCD in adult, we try in our cohort. So it's a monocentric cohort in France, and we had a patient with an extensive workout. So we perform all of the tests for the patient, and we try to look at symptoms specific or at least more frequent in PCD patients. And in this cohort, maybe because it is not a very big cohort, we are unable to separate PCD and cystic fibrosis. So we combine the two diagnoses to make a score. And as you can see, we found different items like age at symptoms before 15 years old, chronic ENT disorder. We have digestive symptom, of course, for CF, and also dextrocardia for PCD. And we had also the detection of Pseudomonas aeruginosa or Staphylococcus aureus in the sputum of patients. So we are I mean, of course, it's a help score, it's a help, especially for young fellow, but it's true that we focus on this item to know if we will look and if we will go to a CF test, which is easy to perform in France, and it's available in many centers, and also PCD test, which is much more difficult to get, and it's available only in few centers in France. So I just finished with my first clinical case. I don't know if you will have some comment or question.
Thank you very much, Bernard. Let's first open the Q&A first, starting with questions from Natalie.
Hello. Good afternoon, everyone. I hope you can hear me.
Yes.
Yeah, super. Thank you, Bernard, for the excellent presentation. I don't see any questions in the chat yet. So, or do you have any hinting?
Yes. Then let's start with my question first. Thank you very much, Bernard. You showed very nicely, first of all, the path to diagnosis of this patient. And maybe it's a two-step question coming from me. And you showed also the nice graph of EMBARK for the differential diagnosis of patients with bronchiectasis across Europe. I noticed that some countries did not even include PCD among those diagnoses. I think this, first of all, shows that there is really very much lacking the awareness for the diagnosis of PCD as a differential diagnosis for bronchiectasis. So looking back with this patient as an example, what do you think would be a main finding or a main symptom among adults with signs would be indicating for PCD? What would you think would be like a waving red flag for PCD?
I guess for me the start of the diagnosis workout for PCD is sinopulmonary syndrome. So it's always, as I say, we have always bronchiectasis in CT scan. So it's very different compared to very young children. And also we always add at least sinusitis or history of sinusitis and ear problems. So at this point, I will think about PCD, and of course, we will start with nasal NO. And as I show in this clinical case, it was not, I mean, very low. It was just a little lower. We repeat twice to be sure there is no problem for the technique. But because we had a high clinical probability, we go very often to the nasal biopsy. We do not perform very often bronchial biopsy. I don't know if Natalie Lorent is doing the same. So these two tools, of course, nasal NO and nasal biopsy, we perform very often. But maybe because I'm lucky and I can get the ENT physician to make the biopsy, and I can get the pathologist to look at the electronic microscopy. As I say, it's not this test is not available in every center in France.
Thank you, Bernard.
I think indeed it is very important to to perform the diagnostic screening, but of course, in many secondary centers, performing nasal NO, performing nasal biopsy is not routinely done. It is done in referral centers with expertise, and that of course probably also contributes to the late diagnosis in adults, because our patients present with relatively common non-specific symptoms, and if you're not, as Ian mentioned, if you don't have this awareness of, okay, there may be other clues to that diagnosis, and maybe I should refer this patient with adult bronchiectasis, yeah, it may be missed, and it is I think an underdiagnosed problem in adult bronchiectasis patients.
Thank you.
There are some questions in the chat,
I
Bernard.
have one question.
One is,
Moshe, what is the relationship between digestive symptoms and PCD? For example, what is the ciliary pathology that implicates the GI system?
Okay, it's my fault because I didn't explain. I didn't have time to explain. So we were not able to perform a score or to look at specific symptoms for PCD. Probably because we don't have a huge cohort. It was 200, 300 patients. So that's the reason we combine two diagnoses, CF, cystic fibrosis, and PCD. So I'm not saying today that PCD is associated with gastrointestinal disease. No. It's just because we combine the two tests, because we are unable to separate CF and PCD just when we are using simple clinical symptoms or clinical evaluation. That's the point. I'm sorry.
That's all right. Thank you. And Ulrika commented on that as well, and you just perfectly replied. That's exactly. It referred to the CF patients, not PCD. We have a question from Denise. Do you have any opinions about arachnobacteria growth?
I should confess I don't know about arachnobacteria growth. Can you explain us more what? It's not a usual bug for me in the bronchial tree, but I don't know.
Whilst we're waiting for that answer, Bernard, can I ask you, like in this era of genetic diagnosis and the first, like the first series of genotypic and phenotypic correlations in PCD, where do you put the role of, where do you put your genetic diagnostic workup, and how can that affect PCD care, management now and or in the future? Could you elaborate a little bit?
In France, because Estelle Escudier was a pathologist and was working a lot on electronic microscopy. We perform electronic microscopy most of the time first. We don't do extensive gene mutation analysis, because geneticians say it's a huge work, and it's better to be oriented by the result of electronic microscopy. But since we are lucky, we can ask very often to the lab, but we are not using commercial tests for that. And so that's just to tell us. The second question is to the correlation between genotype and phenotype. The clinical case is more, I have a couple of slides on this for the first case. In this patient, it's probably not, she had a ASPH1 mutation. It's not a very common mutation, and we know for only case series that this mutation is often associated with a NO, nasal NO level quite normal or a little lower, and also a mild phenotype. Maybe that's the reason the diagnostic was performed in this patient when she was very, very old, or old, I would say.
Okay, thank you. I mean, in our center, in all the confirmed PCD cases, we do perform a genetic analysis. But indeed, unlike CF, it's not with like one gene and several several thousand mutations. PCD is not a single gene disorder, so it makes it indeed a little bit more complicated. But I mean, I think studies have shown that there is some pheno and genotypic correlation, so we may be able to use it in guiding the intensity of treatment and monitoring, as some mutations are related to a more severe disease, as we've already mentioned. And maybe in the future, we will have some targeted therapy, as we are seeing now in the CF population, won't we? Okay. Yeah.
Okay, so I think the question was for Achromobacter species. And
yeah,
PCD.
Indeed.
Okay, so that's, I'm sorry, I didn't understand. So that's, yes, we often, but maybe Natalie will comment, we often see Achromobacter species in bronchiectasis of PCD patients, and chronic colonization is frequent. As I will tell you for the second case, it's difficult to know if the detection of Achromobacter and the chronic colonization of Achromobacter is associated with a poor prognosis. But in fact, when we detect first, but I have no clinical studies to say that, but in fact, when you detect Achromobacter, we used to try, like Pseudomonas aeruginosa, we try to treat with 2 antibiotics for a long time, just to try to be rid of Achromobacter. But I mean, it's just a feeling of physician. I don't have study on that.
Thank you, Bernard. Currently, there aren't any more questions from the audience. Maybe just one final question from me before we move on to the next case. I think you showed very nicely on your first slide that the patient had middle lobe atelectasis. So I'd like to focus again on maybe first pulmonary signs that might be indicating for PCD, especially if maybe some patients maybe are just accustomed to their upper airway symptoms, or maybe the exam does not include any upper airway examination, so people would actually miss the autosclerosis that you mentioned, or any signs of chronic rhinosinusitis. Do you think just looking at middle lobe atelectasis would be also a good sign or good enough sign to think of PCD or to look more into that? What do you think?
Bernard, you are muted.
Oh, sorry.
I'm not sure, Lina, I understood the question.
Sorry, I can just repeat that. You showed very nicely in one of your first slides that the patient had middle lobe atelectasis. So I'd like to be more directly asking, for example, people or patients might be used or accustomed to their upper airway symptoms, might not report them, or the physician might not include the physical examination with otoscopy, so the otosclerosis might be missed. So do you think the middle lobe atelectasis would be also a good enough sign to think of PCD and to then further look into that? What do you think?
I don't know. Natalie, can you?
Yeah. Yes. For me, a middle lobe atelectasis, middle lobe bronchiectasis, yes, it kind of triggers something. Of course, I'm not going to base solely on that symptom, but yeah, middle lobe or lingular, definitely in younger patients will raise some awareness and will be, for me, like a prompt to ask for additional signs and symptoms that may relate to PCD and have a low threshold to perform some additional diagnostic testing. If that is an answer to your question.
Yes, thank you very much. So if there aren't any more questions on this case, let's move on to the second case, Bernard.
Okay. Okay, so the next case is shorter. So it's the story of Mrs. B. She's born in 1964, and she had a diagnosis of PCD in 2002. Actually, it's a little odd, but it was a familial screening because she had her brother with a Cartagena syndrome, and he died in 2002. The family came from Algeria, and so she had a screening, but at this time, she had probably a lot of symptoms before, but probably the family was focused on her brother because he was very ill, and that is probably the reason she didn't get the diagnosis before. So she had also hypofertility, and she had several in vitro fertilization, and she succeeded and had one daughter. And as you can see on the slide, she had a homozygous mutation for the CDC14 gene. So I just try to summarize the follow-up of the patient. She now is our center since 2019, so I missed precise data before that, but I try to summarize the evolution. So you can see that she already had a severe obstructive defect since 2019. And she has less than 1 liter in FEV1. And this functional test was decreasing, but not so much, but decreasing during the time. And as you can see, she had also abnormal blood gases, hypercapnia at the beginning, and also hypoxemia. For the infectious complication, I will say she had a classical history. She had the first primal detection of Pseudomonas aeruginosa when she had the diagnosis in 2002, and she was colonized with Pseudomonas aeruginosa 2 years after. And as you can see, we had more and more exacerbation. She had 2 antibiotic therapy intravenously course per year in 2019. And in 2020, she had 4 IV antibiotic courses per year, and she had also allergic bronchopulmonary aspergillosis. And in 2022, she had several exacerbations, and now she needs to be in hospital for this exacerbation per year. And when we look at what I call ventilatory support, you see that since 2004, we had supplemental oxygen during exercise, just to try to keep the training of this patient. But she had also long-term oxygen therapy since 2019. And we start non-invasive ventilation in 2020, and it's a chronic therapy during night. And in 2020, we need to ask her to use non-invasive ventilation at night, but also several hours during the day. And just to see the weight of the patient and to see the general condition, as you can see, we were not able to keep a good and a weight, and she lost weight until she was 48 kilograms in 2022. So for the disease, if we look at the chest CT, you can see in 2009 the chest CT for the patient, and in 2021. And I think you can see very easily that she had bronchiectasis in all lobes. Actually, it's not only on the lower lobes, and it was a worsening of the bronchial disease from 2000 to 2021. And just to give you an example, of course, it's a French prescription, but you can see the medical prescription she had in our center in 2022. Of course, she had physiotherapy every day. She had, as I tell you, non-invasive ventilation night and also during the day. She had, I will say, maybe less problem in sinus, so she has only nasal lavage with saline 500 milliliter per day, and she got nebulization with beta mimetics and anticholinergic 3 times per day. And you can see the oral drugs, and she still have azithromycin 1 pills per day, and she still have prednisone, corticosteroid, because of the ABPA story, and we had difficulty to decrease these doses. And also she has other disease, like always. She had hypertension, she had also osteoporosis, and so she needs several drugs. So I guess for the question is, which test would you perform at this time? And do you have any therapeutic proposition?
I'm trying to start the poll, which I somehow cannot right now. Maybe Leonie can do that. Thank you. Only one person chose an answer. Maybe there's no right or wrong answer in this. All right, let's close the poll and see. 2 people chose the CT scan. So let's see what was the further development, Bernard.
Okay. So I understand why you have difficulty to answer to the questions, because actually we don't have other test or something to propose to this patient, except we refer this patient to a transplantation center. And she agreed for this project. She had, of course, an extensive medical checkup to be sure we don't have comorbidities. And as you can see, the transplantation, it was a bi-pulmonary transplantation, was performed in February 2022. I mean, it was a success, I will say that. As you can see, 2 years later, she had a normal function test, but as we'll very often say to patients, before they agree to do that, she had a second disease, which is a complication of the transplantation. So she had several infectious complications. She had a bronchial stenosis and so on. So I hope, because now she had a special follow-up in a transplantation center. I hope she had a good quality of life. But it is true that, and we always say that in France, when you go to a lung transplantation, you go to a different disease. So, of course, this evolution is not frequent in PCD patients, but then I can tell you that in cohort in Creteil, we had something like 120, 140 adult patients, and I guess we have something like 10% only of patients we had ventilatory support. And for transplantation, we say probably we will discuss in only 1 or 2% of patients of this very exceptional therapy. So the case also can illustrate a medical complication and potential complication we can have for PCD patient. So you have very frequently talk about pulmonary infection, and it's true that it is very important to assess very frequently the sputum of patient. And in France, maybe we don't have a very convinced data on this, but we use very often antibiotics, and the duration of treatment is long, it's 2 weeks. And we also use very often combination of antibiotics when we deal about bugs like Pseudomonas aeruginosa and also Achromobacter. And in some cases, we use long-term treatment, like aerosolized antibiotics. We use every day for 1 month, 1 month of 2, or sometimes we use every time. And we also often use chronic macrolide therapy. Hemoptysis is a common complication for bronchiectasis. In my opinion, is not so frequent in PCD and it's very rare that it's a life-threatening hemoptysis. So sometimes it's triggered by infections, and I do not have so much experiences in clinical problem with us. We had sometime ABPA, like in this clinical case, but I will say that it's probably less frequent than in CF patients. And it's the same for non-tuberculous mycobacteria. I will have the comment of Natalie on that, but we can detect non-tuberculous mycobacteria in this patient, but it's not very often, and it's very, very exceptional that we have to treat this mycobacteria. Pneumothorax, of course, but again, it's not so frequent, and it's triggered generally by a very bad cough. And like in this clinical case, I will say 10%, but I'm not so sure. We have to deal with chronic respiratory failure. So when we talk about complication and chronic respiratory failure, we will, like a physician, we will be very happy if we will have good prognosis factor for patients. And it is difficult now to be convinced we have this factor. So I try to summarize in this slide what we can observe in the publication at this time. And of course, we had a genetic disease so we may be happy if we can have a good correlation between phenotype and genotype. But we know that it's a rare disease, and there is a lot of mutation, though it's very hard to have a very nice cohort of patients with only one mutation and see one mutation is associated with bad or good prognosis. So I try to summarize here, I think the knowledge at this time, and it's true that it was shown in different study by different groups that patients with mutation of the CCD C14 and CCD C49 genes had a bad prognosis, like our patient in this clinical case, and probably patient with ASPH1 or DNAH11 mutation seems a better prognosis. But a good example would be the DNAH5, which is a very common mutation in different countries. But DNAH1 mutation, you cannot say if there is a correlation between this mutation and a specific prognosis because it's very variable. So colonization with Pseudomonas aeruginosa, this is very common in non-CF bronchiectasis, and in CF bronchiectasis to say it's associated with a bad prognosis. I will show you on the slide after that it's not so clear for me at this time in PCD. And of course, the functional decline, it has been described in other chronic bronchial disease, and it may be related to the severity of the disease. But I will show you again that it's very complex to see that in PCD patient. So to illustrate this question, I took two studies in the literature, a French, a Paris center study, and a London study. And these two studies look at the functional respiratory decline. I choose only these two studies because they are focused on adults. And as you can see, for the French one, of course, and it's true that a patient with chronic PA had less FEV1 predicted compared to patients without chronic PA at baseline, that, definitely. And it has been shown also in the English cohort. And in this slide, you can see that the FEV1 is here, and you have, of course, less FEV1 level in patients with Pseudomonas aeruginosa. Oops, sorry. But if we look at the functional decline and the FEV1 decline in this patient, you can see that it's difficult to be convinced that FEV1 decline is the case for all of the patients. And you can see here in men and in women, even if in women in the French study, they have more decline than in men. We still have some patients who do not have decline. And if we look at this diagram in the English, you can see that it's very hard to be convinced that there is a decline in patient, and some severe patients can have pretty stable FEV1, and some patients with normal FEV1 at the beginning can have a decrease of FEV1 during time. So it is really difficult to be convinced. And of course, in both studies, they try to look about chronic Pseudomonas aeruginosa and more FEV1 decline, but it was not statistically relevant. So it's not so sure at this time, at least for me, that to have a chronic Pseudomonas aeruginosa is necessarily associated with a higher decline of your functional test during the follow-up. So just to come back to the treatment of bronchiectasis in adults, I have to make some advertisement for this very nice British Thoracic Society guideline. So British Thoracic Society performed very good guideline, and they are very practical. And I think it's very good to, this is an example for mainly, the antibiotics strategy, and you can see that they perform step by step. And I think it's a very good way to teach how to manage a patient. And I recommend this guideline to all clinical fellows in my department. And they even perform, algorithm for the deteriorating patient. And I think it's a very nice way to present the clinical problem of everyday practice. And with, first assessment, and in the assessment is, they say always consider underlying causes, and I think it's very important. They said to optimize airway clearance and to look at the exacerbation. And they are, in this case, consider as I should call exceptional treatment. And in this treatment, you can see the non-invasive ventilation and transplantation. So to look at these two specific treatments, for the chronic non-invasive ventilation, there is still debate on other chronic bronchial disease like COPD, that it is very important, and it will change mortality of patients when we are using chronic non-invasive ventilation. And in COPD, recent publication suggests that maybe if we apply chronic non-invasive ventilation in patients after a severe exacerbation, and patients will still have hypercapnia, higher level of hypercapnia 1 month after the exacerbation, maybe it is in fact important to get non-invasive ventilation, but in other bronchial disease like bronchiectasis, we don't have really good data. And there is no specific, to my knowledge, there's no specific publication on that. So I just would like to give you this article from Thorax in 1995, and they try to follow, you see, 180 patients. We had chronic non-invasive ventilation. But as you can see, there is not so much patient and not so much patient with bronchiectasis, and it's not specific for PCD, of course, but what we can see on this table that patients with bronchiectasis are relatively young compared to other disease, but they have more severe disease, as you can see with the FEV1 in liter, and also, as you can see, with the abnormality of PeCO2 and PaO2. For the mortality, I cannot show you the slide, but the result for bronchiectasis was not good, as you can see here. Here, it's just a percentage of continuing non-invasive ventilation during the follow-up. And you can see that most of the patients are not able to continue non-invasive ventilation. And probably, but they are very a small number of patients because they are dying rapidly. So at this time, even if, as you can see in my clinical case, we do use this technique for some patients, I'm not, I mean, we need a really good study to know, at least retrospective study, to know if it's a good approach for patients. It's a very, very, I will say, fastidious treatment. It's very difficult for patients, and it's also a cost, a general cost, very important for at least in France for social security. So I think it's a very important question. For transplantation, again, for PCD, we don't have really series of patients. We have clinical case showing that PCD can have transplantation. And if we look at the American transplantation registry, and this is a table, you know, and there are follow-up patients. This is for 20 years, you know, January 1995 to June 2015. And you can see there are several patients with bronchiectasis, non-CF bronchiectasis, and 1,300 patients who underwent transplantation. It's mostly bilateral transplantation. And so it means like physicians are referred to lung transplantation, this patient. And the good news for once is that if we look at this is the mortality of patients, and the results are quite good compared to other diseases. So in this slide, you can see only the comparison between CF and non-CF bronchiectasis, but you have to know that the CF patients have a much better survival after transplantation than patients with other disease like COPD, interstitial lung disease, and other rare disease. So I think we should think about transplantation in your patient. There is no reason at this time to not refer a patient for a transplantation center. So I think this is my last slide. So just my take-home message for today. That's just to tell you that compared to children, underlying causes for diffuse bronchiectasis are multiple, and it needs to do a etiological workout. And for PCD diagnosis, in adult patients, neonatal symptoms are very often missing. It does not mean people are getting well during childhood. It's just people forgot, or we don't have the records, and it's very difficult to ask patients about this period of life. And as I guess I show you, the alteration, the decrease of respiratory function is very heterogeneous. But we know that in few patients, we can observe evolution to chronic respiratory failure, and we will be very happy if we can have predictive prognosis factor. But at this time, for me, we don't have very good prognosis factor for PCD patients. And I think that's my last slide.
Thank you very much, Bernard, for this also very interesting second case. Let's start the Q&A with Natalie's questions.
Yeah, whilst we're waiting for other questions, I would like to ask you, Bernard, so luckily most of our PCD patients do not deteriorate rapidly, and they maintain a relatively good health, but unfortunately some do develop end-stage respiratory failure. Prognostic markers, you say, like, we lack. I agree and disagree to some extent, in a sense that I think indeed, like some genotypes, as you outlined, are associated with the worst prognosis, and indeed, well, definitely Achromobacter is a difficult pathogen with a high grade of resistance, so often not, and often associated with frequent exacerbations. So complicating the cause. I think in terms of referral, I wanted to ask you, like, when do you think should PCD patients who are declining, when should they be referred to an expert center for assessment whether they are eligible or not for a lung transplantation? And the second part of my question is, we haven't discussed it a lot here, but like, PCD is more than just a respiratory disease, and it's more than just being managed by the pulmonologists or pediatricians. Where do you see an added value? Where do you see the role of the multidisciplinary team, and how and where and who should be part of that to ensure a good monitoring of our patients?
Okay. So the first question was when we decide to refer to lung transplantation center. So I guess, like many adult physicians, the example was CF. So we used to have, before we had a specific treatment for CF. That was the case for most of the patients, because in CF there is no way that the functional deterioration happen very, very often. And so I guess we keep the same item, but I'm not sure it's the same in every country, because of course I guess it depends on the availability of lung donors and a transplant center in each country. But at least we start to think about that when we got at least FEV1 less than, I guess, 30%, and I insist for PCD, and a number of exacerbation, like in our patient that we have a kind of acceleration of exacerbation in the patient. But it's not only a functional number, because as I show you, some patients can have very, very low FEV1, around 30%, but they can be stable and without exacerbation for years. So I know it's difficult, and it's a kind of combination. And I will say something which is not politically correct, but also the transplantation center change the criteria to refer patients because they have much less, as you know, CF patients at this time. So it looks like they ask us now to probably send the patient probably early on. So, yeah. And I guess this is not a medical assessment. This is just a question of do we have a huge list of patients waiting for lung transplantation or not? So that is your first question. And the second question, of course, I did not talk today about the multidisciplinary approach, but for me, the most important is the physiotherapist, of course. I know, again, in the position of physiotherapists can be very different in different countries. But I think this is it is the main, the cornerstone really of the treatment for the patient. And also because I'm very lucky, but have a huge ENT center, and of course the ENT is very, very important, and we are for the follow-up of adult patient in always in both physician, ENT and lung physician.
Okay. Thank you very much, Bernard. Katie has a question.
I had a question about, excuse me, Pseudomonas aeruginosa. So in your PCD patient cohorts, do you typically see mucoid or non-mucoid strains, or is that something that you look at or that you've noticed that the publications out there look at?
I will make a comment, and probably Natalie we say maybe also something, but this it was in the early publication in CF that people were look at mucoid and non-mucoid colonies of Pseudomonas aeruginosa. It's true that at this time we are not looking at all on this characteristic in our everyday practice. So I don't know if Natalie will still use this classification or not.
Yes, we always get the specification of mucoid or non-mucoid. As with CF, as with the other bronchiectasis or COPD patients, we're more likely to see the mucoid form in the chronic patients where the biofilm is already present, and of course these ones are harder to treat. I don't even dare to say eradicate, because that's most of the time hopeless once they're mucoid. Whether they are associated with poor prognosis, well, in general, I think Pseudomonas, definitely a chronic Pseudomonas infection, has shown that it is associated with less quality of life, more exacerbations, and so on. Yeah, whether it is crucial, I don't know. I mean, as the nurses in their center, it is not done routinely in our residues.
Thank you both. Next question coming from me. You showed in the first slide that this patient was diagnosed by familial genetic testing after the brother died with the diagnosis of Creteil syndrome. So right before that familial genetic testing, under what pulmonary diagnosis was this patient?
Do you mean should we change our therapeutic approach depending of the mutation?
No. From what I understood from your slide was before the brother of this patient died with this diagnosis of Creteil syndrome, and then just afterwards she was diagnosed genetically, right? But before that, her own diagnosis, before that genetic testing, under what diagnosis what she cared for?
She had just an electronic microscopy. I don't remember when we detect the CCD14 mutation, but it was probably in 2019 or something like that, 2020.
Okay,
but
so
she had a diagnosis of PCD in 2002.
Right. And so
probably based on electronic microscopy and of course familial history.
Okay, so it was more like a clinical suspicion or clinical diagnosis before the genetic was done, right? Okay, thank you. Natalie, do you have any questions? You're muted.
Sorry, no, I don't have any more questions, and I don't see any more questions in the chat either.
Yes. Okay. Katie, we'll move on.
Okay, in that case, we'll bring our session to a close. So thank you both to our expert speaker and expert moderator for a super interesting session.